Okay, good afternoon. Today is July 15th, and it is 4:02. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Ad Hoc Litigation Committee. I think all of our committee members will be here in person. Dr. Martin will be here shortly. Public communications, I don't believe we have any right now, right? No, okay. All right, so we're going to proceed to the committee agenda. So, the first item is to receive, discuss, and take appropriate action on an update from counsel regarding Ascension litigation. So we're going to be going into closed session. I announce that the committee is convening in closed session to discuss agenda item number 1 under Texas Government Code Section 551.071, consultation with attorney. Okay, all right, it is July 15th, the time is 6:27, and we're entering open session. Members, let's see, we have our last item, which is confirm the next regular ad hoc litigation committee meeting, date, time, and location. We do not currently have one scheduled. We'll schedule as need be. At this time, I'm ready to accept a motion for adjournment from.
I adjourn.
You make me laugh. Manager Musaitis and second from Manager Brinson. All in favor?
Aye.
Okay, it's adjourned.
Can we have 5 minutes?
Yeah.
Okay, thank you.
They have food next.
All right, I'll get
They have brisket.
Okay, perfect. Well, good afternoon, everyone. Today is July 15th, 2025, and it is 6:40 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, do we have anyone online from board members? No.
Lisa May here.
Oh, hi.
Hi, everyone.
Miss you.
Finally got through.
Wonderful. It's great to see you. So we
Thank you.
have Manager May online, and we will staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. For public communication, we have an opportunity for public communication was offered for today's Budget and Finance Committee before the Litigation Committee meeting at 4 p.m. However, if a member of public wishes to comment on specific item on this Budget and Finance Committee agenda, they may do so at this time. Are there any public comments for this meeting? No. So there are no one signed up. So we will proceed to the committee agenda. I just want to acknowledge all those who, the past flooding that happened recently. Our hearts go out to all the families and parents who have lost a loved one. I have no words except, I'm sorry and my deepest condolences to you all. And if there's anything that Central Health can help and support any injured community members within Travis County, they may reach out. And I believe Central Health has released some contact information for those who may need our services.
Could I add just one thing?
Yes, Chair.
I want to thank, I think I saw a notice from our communications officer from TAD
Yeah.
and his team on the work that he did to be supportive to the community. So I want to say thank you. I don't see him here now, but thank him for that. And thank you, Pat, for the support.
We still have 160 missing people, unaccounted for.
Yes.
160.
I have no words. I just wish their family peace and comfort and closure. Okay, now, members, we're going to proceed to agenda item 1, receive an update on fiscal year 2025 Board of Managers budget proposals. Members, I know several of you have submitted budget recommendations for fiscal year 26. I was hoping that we can discuss it this evening. Unfortunately, they are not ready to be presented to us. They will be by next week. Staff are still meeting with community organizations in trying to find a resolution to those recommendations. So I just want to let you know we have not forgotten on that item. So it will come to us next week, right? Okay, just want to confirm. So thank you, Anissa, Monica, and Jeff. So you'll be presenting on these. These are the recommendations that we all presented and were approved for last fiscal year 25. So this is just an update of those proposals and where they're at. Thank you. Go ahead.
Okay. Good evening, managers. Thank you again for the opportunity to present a progress update on the FY25 board member budget proposals. Just a reminder, the backup was provided in the June 25th backup. So hopefully you've had an opportunity to review. But being respectful of your time, we're going to focus on the key updates, but the full details are available in your packet. Okay. So looking from this table here, just a reminder, there were a total of 12 proposals. On the right, those 7 were aligned to existing priorities, and the 5 to the left in the green shaded were recommended for business cases or an RFP as new planned work with an update, and we're going to start with that update first. Next slide. Okay. The following 3 slides are abbreviated. They are laid out with the board member's name on the left-hand side. The middle column has the proposal, a high-level abbreviated description of the proposal. the recommendation from the staff from last year, and the right column has a progress update as of today. Okay, so we'll start with Manager Musaitif. There was a proposal submitted for improving survivorship through integrated data sharing and provider education. I'm going to skip the recommendation and just provide the progress update if that's okay. As of right now, staff is developing a job description and process to integrate an oncology navigator within the Ascension Breast Clinic. They've also enhanced co-management of complex cancer cases and care coordination. Through Central Health Supportive and Palliative Care Team, and we've also expanded access to colonoscopy and Cologuard screenings. Okay.
Great, thank you.
Manager Valadez, the next proposal was to increase funding to support an implementation of a Hispanic Family Support Conference. I am proud to announce, hopefully correctly, Viver con Ganas Community Health Expo will be held on September 27th. There were 3 advisory committees that helped make up the evaluation. That was staff, community partners, and patient members. They're hoping to engage 500 participants, and they are marketing that there'll be free transportation, on-site childcare, mobility assistance, and virtual attendance options. Yes.
I just want to again reiterate that this was originally put forth for the non-English speaking community, whatever language that was. We know the majority of those that are here as patients in the MAP program and MAP Basic, and also in our community under the those just seeking care, maybe mostly Latino or Spanish or Chicano or Mexican or whatever, but we have all these other populations that have yet to, I think, be brought to the table adequately in the Asian community and the Middle Eastern community. Also reaching out to the religious affiliations, different religious affiliations and languages. And I want to make sure that we understand this is not for Spanish speakers only. This needs to be for non-English speakers. That's what this was originally for. So I just wanted to reiterate that, because we do have lots of communities that I don't know that they feel particularly welcomed. And I want to make sure that they are, because they are part of us. Thank you.
Thank you, Manager Valadez, for that. I have a comment. Is this a hybrid event?
Yes.
So, have you all sent us an invite, a hold on our calendars for board members to attend? Are we invited to attend?
I would assume you're invited, but I have not. Well, we can take that back to the communications team to ensure that you have an invitation.
So, yeah, we would love to
Yeah.
attend if we can. And thank you for being inclusive, Manager Valdez.
Manager Wine, did you have a question?
Oh, I just felt like anytime, and this is just a sort of a personal thing, but anytime we're talking about languages or communities who ought to be involved more, I just want to point out that those of us remember when our Afghan allies were rushed over here to this country, they were met with an administration that was recognizing the value that they served, and also the risk that they face in their home countries, and afforded them a lot of the transitional, although nonetheless inadequate, requirements to be able to adapt to a very, very sort of caustic change of life conditions over here. I've been getting some signals from the community that I haven't personally verified, that it just seems like the enthusiasm isn't there anymore, and a lot of the communities are kind of just left to sort of fend for themselves, particularly in the healthcare environment, but also uniquely as related to language and translation. I think it's very easy for us to use typical language line resources and similar, but just anytime we're talking about language, particularly for our Afghan allies and that population that's here, many young children and families, just anything we can do to provide adequate support services, particularly language appropriate in Dari and Pashto, not getting someone from a country nearby who speaks a similar language, but getting the right sort of language assistance. Sorry I took that time, Chair.
Thank you
Just
for
to-
raising
Just
that.
to add, to make sure that we understood, it's not just about the interpretation lines being expanded, it's about hiring people that reflect those communities, so that when they come, they have somebody that they can speak to and who looks like them, face to face.
Thank you both for raising that. Okay, to proceed?
Yes, please.
Okay. Manager Kitchen, there was a proposal to increase funding to support expansion in programmatic areas of Integral Care's MCOT and field response team. The staff has been engaged with Integral Care through joint planning throughout the year to support the expansion and preserve Integral Care services in the community. They are also working to complete a mental health system of care mapping exercise, and there are investments included in the FY26 budget as well. Okay. The next proposal actually was proposed in both by Manager Kitchen and Manager Matwani around food as medicine. As you have supported, Shift 2.0 does target food insecurity and supports patients with specific health conditions. Weekly mobile food pharmacies launched in June, and we plan to expand from 4 to 6 mobile food pharmacies a month at identified central health and CUC locations. We are also developing an RFP for quality control vendor starting next week. Yes.
So the program, have we started providing the services related to food insecurity?
We have started
microphone.
the food pharmacies. I'm not sure if the food as medicine has actually started, but we have, I think, during the last meeting, we had just hosted the first expanded food pharmacy site, and I think that since that last meeting, there's been a second one, but we can bring back an update on the CHIP 2.0.
Is the expectation, we put a certain amount of dollars into this for this year, I believe. I don't remember how much it was. Do we expect to expend those dollars this year?
I think we would be on target for the first two parts of it, for the food as medicine and for the food pharmacy. That third part, which is the workforce development around food insecurity, is still, we're having to put that back out on the street for an RFP. So remember, this is a 2-year program cycle, and so I think within that 2 years program cycle, probably the first 2 are green light, the third is a yellow at this point, but we're going back to the street.
Okay, well, I don't need this right now, but I would like to know the dollars associated, what we expect to expend this year, what we've expended so far, versus what we budgeted. So, go ahead.
And just jumping in, this was, when we're talking about the dollars expended for the subsets of the food as medicine program, we're talking about CHIF dollars, right? The RFP. So there was an RFP done. 2 out of 3 were awarded. Third is going back out to RFP. So highly probable, if we award a third, that with the appropriate timelines, those dollars will be expended, and of course the services will be realized, or at least
It
beginning to be
depends.
in-
It depends on, that's what I'm asking.
Yeah.
In other words, just because we awarded it doesn't mean we've written a check.
Oh, for sure.
Yeah. So that's the level of detail I'm asking.
And I guess the second question was then, the dollar amount question was, those dollar amounts were already kind of predetermined in the CHIF RFP, right? There was a ceiling, and I'm guessing people applied to the ceiling. Do we know off the cuff what that was?
I do not. No.
Okay.
So, but we can look back to
Sorry
the
about that.
contracts
Now
that
we're good.
were awarded, what was budgeted, and
So-
what we
1.2.
spent.
Maybe you can provide us in an email. Thank you. And the orange, the color code, you had green, they've
Yeah, so
been
the green was new proposals or new work, and the orange aligned to existing priorities.
Okay.
Okay. And it's also at the top of the slide as well for reference. Okay, good to move?
Yes,
Manager,
yes, Manager Jones?
you said the orange are existing as interpreted by,
As in, we had work already in those areas, and so that we align those proposals and continue to expand based on the proposal to that work that was already aligned there.
okay, so you all decided that we're already doing this type of work, and so therefore that recommendation falls under that.
Yes, and that was
And
discussed
this
last year's
was from
recommendation.
fiscal year 2025, so this was a process that staff brought to the board, received feedback from the board.
Can you turn on your microphone?
Oh, sorry. That this was a process this is an update on the fiscal year 2025 ones. And so staff took the fiscal year 2025 proposals and it made recommendations based upon whether this was something that we thought work was underway. Can we fit this into that work? We brought those recommendations back to the board as part of the budget development process, received feedback from the board on whether we'd hit the mark or not, and then amended what was actually included in the budget and what work was done based on the feedback that we received from the board last year. So this wasn't something that staff decided. This was something we worked with you guys as a board to, come to the final, final implementation and alignment on.
Okay, I have some concerns about that, but I'll allow us to go through this, because as we go through different ones, I'll identify if I concur with that interpretation of what you've said, so.
Okay, can you then advance to Manager Jones's recommendation? And then we can,
Okay, so it's actually the first one. So Manager
Yes.
Jones, there was a proposal to enhance outreach and clinical services for men of color by directly funding community service providers and agencies. We continue to strengthen collaborations with the Black Men's Health Clinic, African American Youth Harvest Foundation, and Hungry Hill Foundation. Key services included for the Black Men's Health Clinic, continuing to work with community care to enhance clinical services and enhance outreach to serve individuals of all racial and ethnic backgrounds. Under the African American Youth Harvest Foundation, we expanded the contract to support psychiatric and counseling services for families and children impacted by trauma. And under the Hungry Hill Foundation, we expanded access to mobile clinical services, including MAP and MAP-B enrollment, assessments, and navigation support.
do you have any comments, Manager Jones, on that?
No, I think you've covered
Your mic,
Yeah, this Hungry Hill one I wasn't as familiar with or engaged in, so that's why I asked you.
Okay.
But the rest of them, yeah, I'm comfortable.
Fine with
And
that.
I'm comfortable with Hungry Hill too now. I've gotten to
The
work with
information?
them, yeah.
Okay, thank you for that.
I just have a point of, so members, would you like them to go over all these recommendations right now, or are you fine just reading them off? Sorry, like for time's purposes, I just wanted to know, what's your thoughts? Are you fine with whatever is written?
Do we have people that are gonna be leaving early?
I think the reason why we have two hefty agendas. Yeah, I don't, again, whatever you are comfortable with, I just wanted to provide you with this option.
To answer that question, I think my name was next to, multiple proposals, but there was really only one that I wanted to follow up on. And
Okay.
it didn't need to be a long follow-up, really, so.
So we can do
we'll get to
that.
But I don't think we need to necessarily belabor all of them. I defer to you, and I definitely understand the time tensions that we have to manage, so.
So can you state what your question on which proposal, I think, to be more efficient?
Yes, first of all, thank y'all. Secondly, just to reaffirm, green was new stuff, orange was expansions. Green was new lines, oranges are suggestions that were expansions of existing lines, if you will. Okay, so then I'm looking at the orange page around premium assistance program. And effectively, proposal was to expand, at least do what we could to study the feasibility around expanding premium assistance programs to provide coverage for underinsured either service or hospitality industry employees. I can see the progress update there. It's a little distinct from a feasibility study. It does make sense. And also, I know that the health plan was doing a whole lot of stuff last year, and I don't live under the illusion that we have infinite resources. So understanding that finite resources are going to solve what we can when we can, strategically. But just want to get a sense around if there is a chance for a feasibility study to possibly end up in this budget year. Because I think the main concern, of course, is we don't want to jeopardize a risk pool by identifying a target pool for premium assistance. So if we could maybe,
Yeah,
and we don't need to belabor it, we can take it offline too. So.
Okay, great.
So, could I add to that? I also think there's an aspect of premium assistance that is really important that we explore now, related to the fact that ACA is losing the federal match for some of the low-income folks that have a premium assistance match for participating in the ACA. So I think that I would like to suggest that we accelerate considering whether we can do something, because I'd hate to, and you don't have to answer it now unless you know
Yeah,
something, but I hate to see all those people fall off of insurance. If there are some of them that if we just helped them, or if there was a way to help them with part of their premium, they could still pay part and stay on. And that relates also to the item around Tex Health. I'd like y'all to get back to us with some more detail about what the potentials might be.
Yeah,
So
and
why don't we, following a suggestion provided earlier, Chair Kitchen, we'll grab those questions. We'll provide feedback afterward. And just want to make sure we
So-
capture those two different questions that we can
Okay.
provide feedback. Great,
For
thank
next
you.
week before budget, if possible.
Either live or potentially brief written. We'll work out the
We
best
could,
way.
in August, I mean, I'd just like to get an answer
Oh,
before
yeah.
we vote.
That's what I'm saying, absolutely.
Yeah.
So, because it's a budget recommendation by board members, I think everyone should be aware the response that you'll bring forth.
Great.
Okay,
And just one last,
so,
just one comment.
I'll come to you.
Okay.
So, Manager Matwana, just want to make sure you had your answer.
Yeah, and I also thank you, Chair Masaida, for checking back in. And just I want to make it clear that like this idea is aspirational, and it's really around studying to what we can do. We talk about our low-income population here in Travis County, and who are uninsured or underinsured. We're talking about 100 to 200,000 folks. Estimates of those in the service and hospitality industry is around 100,000 folks. If we paid premiums for everybody at $10K a year, but for 100,000 folks, that's 100. That's 100 million. That's a I want to make sure that y'all know that I know that, and I want to approach it that way too. But
Yeah.
to Chair Kitchen's point, despite the lofty cost of it, it's definitely something that we need to study and understand.
Just to make a quick comment, there have been some, as far as recent legislation, I mean, it's a somewhat of a complex assessment, so we hear what you're saying, but there are gonna be some complexities to it and some factors that we may wanna take into consideration.
So you'll do the best as you can. Manager Valdez?
I'm sorry, it was just, since we were late receiving, Bedla's, impact on, House Resolution 1, and
That's
if,
for the next
the only reason I was
agenda item.
bringing it up is because of the impact on ACA.
yeah.
And so just, Jeff, I know that's what you think, I think that's exactly what you're referring to, so thank you.
And Manager
thinking about
Valdez, we will be discussing that at the next agenda item. Okay, members, I think we've covered most of these recommendations. Do you all have any further questions, comments? Okay, thank you all, appreciate
you.
it. We look forward to the fiscal year 26 board recommendations. And just to make sure that these recommendations, you'll continue on, they won't pause. Whatever recommendation was will carry over to the next fiscal year and forth. Okay, thank you. Now, As I mentioned, we'll discuss fiscal year 26 at our next meeting. Now, moving on to agenda item number 2, receive and discuss an overview of legislative and regulatory issues impacting central health system. Members, this is going to be from now on a standing item on our Budget and Finance Committee because, as we all know, things are moving at a rapid pace. So just to keep up with any updates, so wanted to make sure that staff have brought it to our attention. So Perla, Rob, and Katie, thank you. You'll be presenting on this item, and I understand this is going to be an open session. Unless we need to go in closed.
This will be an open session update, and on Friday with the board packet, we did email a few backup documents. One is including a July 11th Government Affairs report out, which Rob Borja, our Director of Government Affairs, and Alicia Ramirez, our Manager of Government Relations, are now putting together for Central Health staff, and it's a bi-weekly government affairs update, which we will start sharing with the board as well. But it's a nice wrap-up of what's going on at the local, state, and federal level. So hopefully you had a chance to look at that, but in that report, you'll see a couple of items that we will also be giving verbal updates on today. The legislative session has also begun, and I'm going to have Rob give an update on that. As you all are aware, there was also, at the federal level, there's a lot of action happening, including the Budget Reconciliation Act signed by President Trump on July 4th. So we want to give you an update of our analysis to date, which Katie Coburn, our Director of Federal Healthcare Finance Policy, although we pull her in a whole lot for federal analysis, it was also contributed to that slide deck. So that slide deck was also in your backup, and hopefully you had a chance to look at it. We will take a look at it. What I did send you today, earlier this afternoon, was also some more details about the special session and then a press release from Health and Human Services at the federal level about a policy change. So again, these updates will be adding them as monthly updates just because the special session and the much of what is happening at the federal level that we are trying to analyze how it's impacting our organization, some of which is very significant, including to the populations that we serve.
So, Perla,
yes.
You mentioned monthly. If there is any significant change, I ask that you communicate to us board members via email if we're not in a meeting, if there's anything that
Absolutely.
needs to come to our immediate attention.
Yes.
Thank you.
I can do that. So with that, we're going to start with the state update. I'll hand it over to Rob Borja.
Okay. A week from yesterday, the first called special session will begin. Last week, Governor Abbott issued his proclamation with 18 agenda items for the first special session. Agenda items include the regulation of THC, improving emergency response during floods and natural disasters, improving preparation and recovery for natural disasters, and congressional redistricting. Of particular interest to Central Health were two agenda items. One is to cut property taxes. The wording on the governor's release said legislation reducing the property tax burden on Texans and legislation imposing spending limits on entities authorized to impose property taxes. And then the second agenda item of concern is a ban on taxpayer-funded lobbying that's been attempted at the legislature for several sessions now. Pre-filing for the special session began yesterday, and while there are a lot of bills that have been filed on those two particular agenda items, none of them that have been filed so far appear to be the primary bills that will be moving through the special session. So that's sort of where we are right now.
Thank you.
And we will keep you updated. We can come back next week and give you another update. Next, we want to move into, unless there are any questions, we want to give an update on the Budget Reconciliation Act, H.R. 1, also called the Big Beautiful Bill. We are calling it the Budget Reconciliation Act. And so that should be in your packets. Brianna's pulled up the slide deck, and with that, I'm going to actually hand it over to Katie to kick us off.
Yes, thank you. We're going to tag team these updates for you because, as y'all I'm sure know, there's a lot of information, a lot of change that happened in this bill. As y'all know, it was a budget reconciliation, so these are budget policies that have been changing. The effect of those, high level though, is that fewer people will have healthcare coverage as a result by 2034, which is after everything has taken effect. Kaiser Family Foundation is estimating that 1.7 million Texans are going to lose coverage either through Medicaid or through changes to the ACA, including the non-renewal of enhanced premium tax credits. So we're definitely taking a look at that. On the provider financing side, there are also a lot of limitations placed on those programs as well. The net result of that, we would think, is that uncompensated care costs in hospitals nationwide and other providers is going to rise. So we'll need to keep an eye on that. A key point to remember that bleak as it is, Texas did not fare as poorly as states that did expand Medicaid. So there are some protections that we are able to benefit from that we'll talk through. This Budget Resolution Act does not contemplate 340B, although there is a presidential executive order that does, and so we're keeping an eye on that happened previously. We've updated y'all on that in the past. So obviously 340B is very important, so we are keeping an eye on that. The other thing it does not do is extend community health center funding. So that is going to have to come through an appropriations process. That funding expires September 30th. With the cuts to the budget, but also increased spending and tax cuts, there is a risk that overall federal spending could be limited by sequestration. We don't know what that is, but we're definitely watching very, very carefully to see specific cuts and how they're going to play out locally. From there, we can talk a bit about some of the different types of impacts, and I'll just go over high level some of the impacts to the hospital payments that we talked about. So provider taxes, this is like our local provider participation fund where providers pay in to provide the local share of Medicaid payments. Those were in the bill frozen at their current rates across the country. So wherever they are, the different type of taxes they're frozen where they are. For Central Health, the impact there is the LPPF that y'all have is currently at the maximum rate it can be, which is 6%. And so our program can stay there, and that's the highest it can go. So in that way, is no change for us there. In expansion states, those maximum payment rates are going to start reducing down to 3.5% at some point. Another thing that happened in the bill was that Medicaid-directed payment programs were capped at Medicare payment rates. Now, Medicaid-directed payment programs are specific programs in Texas you've heard me talk about when we talk about the LPPF, CHIRP, the Comprehensive Hospital Increased Reimbursement Program. These are Medicaid programs that, in general, enhance payment rates for Medicaid encounters, and they use IGT to pay for it, or LPPF funds, or local funds. Those programs were capped at lower payment rates than they're currently set. In Texas, you can well, it's lower. It's down to Medicare, so it's less money. The exception, though, is that if those programs were submitted for approval before the date of an enactment, they are grandfathered in at their current payment rates through, I believe it's 2028. That is Texas' situation. So the directed payment programs here are going to stay at status quo through 2028. After that, those programs will start reducing 10% per year down to 110% of Medicare rates. One thing to note is that the bill does not mention at all anything to uncompensated care funding, which is a different type. It's not a Medicaid-directed payment. We haven't heard any talk that this bill would affect that funding source. And then finally, for me, before I hand it off, there are cuts to the disproportionate share hospital program, another supplemental payment program for hospitals that have been contemplated since the Affordable Care Act went into effect. Those cuts have been delayed, and they are scheduled to go into effect in October of this year. This bill did not delay them, so we are expecting those cuts to take effect unless something changes between now and then. THA has estimated for Texas that's going to look like about a 33% cut in DSH payments. Could affect about $20 million coming to Travis County hospitals generally. So definitely another reduction in payment that we'll need to be watching.
So for Travis County, 21 million?
So this is an estimate that the Texas Hospitals Association did based on congressional districts, and looking at Congressman Doggett's district, they are anticipating about a $21 million cut across all the hospitals in his district.
That is significant. Yes, Manager Jones?
But the persons who live in his districts are not necessarily all supportive of this initiative, are aware of the impact it will have on them. The assumption is that the district is reflective of, the congressman is reflective of the district, but there'll be many other folks in that district and other districts will be disproportionately impacted by this. And so when we get ready for questions, I like to talk about strategies we need to talk about in terms of how do we get that message out proactively as opposed to reactively.
That's a great point, thank you. Yes.
And just another way of looking at that is that there'll be an estimated decrease of $21 million in payments. But remember that these cost reports are submitted a year, about data a year behind. And so basically this is just a $21 million uncompensated care cost that will be covered by whatever hospitals are paying it. In other words, they won't be reimbursed back for it, or they won't be paid for it.
So would there be a possibility of any hospitals to go bankrupt because they're unable to pay off those costs? So I'm just wondering, in terms, because that is really significant, that is just Travis County. And if they're paid a year later, and how do they compensate, and what is the impact for our patient population as well? So I'm just wondering if we'll hear hospitals filing for bankruptcy. I don't know. I'm just curious to know.
That's a question for them. I think in Texas, rural hospitals that are independent, that are by themselves, are more at risk. Thank you. They're more at risk than hospitals with systems. And it's a great question to ask hospitals, is whether or not they can absorb the cost or not. And again, remember, federal law requires that they provide care for patients in the emergency room. So it's a pressure point, and hospitals are better positioned to explain this.
So could we get some answers related to that in the future from hospitals? How they're navigating around it? What is their strategy?
Sure, we can do that.
Okay,
And
thank you.
we're lucky to have a former government affairs officer for hospitals on the board as well.
Well,
I
you
think
should-
that is,
You should
All your
really,
friends, all your buddies.
well, you should really thank the American Hospital Association. They're the ones that have effectively pushed this dish hospital funding cuts out
Yeah.
every single time.
but
They're-
now,
And they'll do it, well, they'll try to do it again, but I think, as a staff, probably will tell you, there's a number of organizations all focused on these issues. The biggest one that's a concern that should be of concern to our community is around the caps of the Medicaid directed payments, because the difference between paying a percentage of Medicare and the average commercial rates is significant. And that doesn't happen until 2028. So I think there's probably some contingency plans that our staff can ask our partners about as they try to manage their provider participation, which is the 6% of net revenue, net patient revenue.
thank you.
Sorry.
Thank you.
No, if we can get some answers and clarity around that, it will be very helpful for us.
To emphasize, having the information is critical. But we're in a short time frame for this federal budget to be passed. So the question is, what can we do in terms of informing the public of the implications that could come from these types of actions that would trickle down to us, but also to surrounding areas. So as we're looking for getting those answers that you're talking about, I think we might need to look at a strategy to be able to respond.
I think the first one is awareness, because that's the easiest thing that we can do, and we should be sending out that message of what the local impact on our patients is. And then we can, as we're going, we'll discuss more further strategies. So that's the first thing that could be done right now.
Right, and that's my point, is that let's not wait till the last.
Oh, no. So if we can, I will get to you, Manager Matwani. So if possible, to get that messaging out. So how does everyone feel around that? So that's an action item for you, Perla, and your team. Manager Matwani?
Yeah, I think that was actually it. I was just going to ask if we could put that as an agenda item for the next appropriate meeting time, that we could explore messaging ideas around managing expectations as related to potential budget shifts, managing expectations of our patient population as related to budget shifts.
So perhaps because this is a standing item, they'll have some verbiage, something that you can share with us at our next meeting, some ideas that you can discuss with us. Because it's very timely, and it's a timely matter that needs to be out. And I haven't seen anything out from anywhere. So,
A lot of the advocacy is, and we can certainly talk about strategy and messaging, a lot of the advocacy is being done by these associations. We've been in communication with the Texas Hospitals Association, with the Teaching Hospitals of Texas. We're members of America's Essential Hospital. We've also been in communication on some of the other provisions in this act. We've been in touch with the Texas Association of Community Health Centers and the National Association of Community Health Centers, and have sent emails to our Congress people with messaging that the associations have provided us. That we can share some of that with board managers
yeah,
as
so
well.
maybe you can use some
Yeah.
of that messaging as well.
Yeah.
I think aligning our messaging with them. It's not just creating our new messaging, it's like pushing it out from our, from Central Health. Manager Jones?
I would emphasize though, is that people, our community
Right.
gives more credibility to hear this from us than from the American Hospital Association. I have nothing wrong with them. I think they do a great job, but I'm saying that's where they're gonna hear it from.
Yeah,
And so,
I agree. So using their language, but it's coming out from Central Health. So we can adapt it to us. Dr. Brinson?
And can we include people's representative in their communities or in Travis County or whatever, so that they will know what vote those representatives took?
Yeah, how are they voting?
How did they vote?
How did they
Okay,
vote?
I didn't hear you, but I'm sorry, can you speak
Sorry,
up a little bit?
And included in that messaging,
Yes.
we should include what the representatives of their communities voted.
How
Did
did
they
the
vote
Congresspeople vote?
for
How
or
they
against the
voted.
bill?
How did Chip Roy and
Yeah.
Mike
Right, exactly
That's
right.
right.
Because that's what they need to know. They don't just
Okay,
need to know, they need to be able to do something with it.
This is,
So, yes, Manager Valdez?
it's not for partisan reasons. This is done for people's health, for their health. This is their life and death situation for some people.
Well,
And the more we explain to them why they are going to be at risk, up to 400% FPL, losing losing everything with respect to ACA or that going out the tubes, or the hospitals not being reimbursed, or not having access to those dollars. That's going to affect services. Small rural hospitals being closed. So the population needs to know, and they need to know where it's coming from and why we're in this boat.
so, yeah, so we all agree in that. So the action item for the coming week is for you to adopt some language that is tailored to our community. And we will, as a board, think of strategies how to mitigate these risks if we can, however we can. Yes, Manager Motwane, and we'll quickly.
Yeah, well, I was just wanting to honor and acknowledge the notion that a lot of the stuff is still in process, particularly the special session stuff. So in my request for having that agenda item, I was just framing that so we didn't lose it in the wash, but just like what the messaging strategy will be for our population to manage expectations around budget shifts. That being said, understand that the stuff is going to be churning for a while, and that there will be a final set of messaging, hopefully, that we would go with once the dust has settled, if we will. So that, I just wanted to clarify that. I wasn't necessarily looking for immediate messaging next week, but once the dust has settled. Thanks.
I think the sooner the better. Just really, this is the current status of what it is as of today. The date will be relevant. People need to know. It is, and going to Manager Jones' comment, we need to be proactive, not reactive. Okay, so moving on. So respect for time.
Yeah, I can just touch on ACA coverage real quickly. I know we're pressed for time, and there's another agenda item after this, but we were talking about the ACA impacts of the Budget Reconciliation Act on the ACA coverage. I have 4 provisions here laid out. The one that I will bring to your attention is one that was not included in the Budget Reconciliation Act. It excluded a provision to maintain enhanced premium tax credits, so we expect those enhancements to expire December 2025, and per the conversation earlier, that will impact Sendero and some of their members that receive premium tax subsidies. And I kind of broke down, it's tiered just based on what your income is. And so for individuals at 200% of the federal poverty level and below, they'll lose between 2% and 6.3% per month on their subsidy. And so this is something that we have discussed with Sendero as well. And I'm gonna hand it, I'll let you all read that. I'm gonna hand it over to Rob just to close out the last slide.
Chair Kitchen?
I have a quick question about that.
Yes?
Just because I'm not familiar with what that means. When it says we'll lose 2% to 6.3% a month, what does that mean? Does that mean it's gonna
Yes.
cut the amount of their premium assistance by 2%?
Right, so during the Biden administration, so the ACA provided premium tax subsidies to help individuals pay for their health plan, their ACA health plans. Those the enhancements enacted by the Biden administration expire in December. It looks like the Trump administration will not continue those. So let's just say, as an example, someone at 200% of the federal poverty level that has a $600 a month plan, and, they're getting a subsidy of 6.3%. They're getting about a $36 per month break towards their plan. So at the end of the year, that adds up to $432. So that is an enhancement that they will no longer receive. They'll still get some subsidy, but they won't get the added Biden enhancement.
Okay, so the amount, they're still getting some subsidy,
They are
but
still
the
getting
amount
some.
is reduced.
Right.
Okay.
Okay. Thank you. Proceed.
Okay. There were also Medicaid eligibility changes. The main, the sum of the effect is it will make it harder to get and keep Medicaid coverage. Right now, when you apply for Medicaid, you get 90 days retroactive coverage. Now that'll be reduced to 60 days for non-expansion states like Texas. They are narrowing the definition of qualified immigrants who can get Medicaid coverage. The main groups that they are taking out are refugees and asylum seekers. They're no longer going to be eligible for Medicaid coverage. They are going to be increasing address and income verification. It'll be more frequently, and there are going to be specific databases that states will have to use to verify address and income. And then there is a work requirement that's being put in of 80 hours a month, but it'll affect very few in Texas because it applies to non-disabled, non-elderly adults, and there are very few of those receiving that in Texas.
Okay. Well, thank you. Does that conclude your presentation?
So we have one other quick update. We are still doing due diligence, but HHS, Tara, you want to come up, and then Rob, maybe you can give her your chair. Just a quick update. We'll come back next week or at a future time to give a more robust update on this. We're still doing due diligence, but Tara, do you want to?
Sure, absolutely.
give an update?
Thank you so much for the opportunity to give you all this update. As some of you may be aware, late last week, we received early word about new guidance coming from HHS that was officially published on Monday that essentially removes a carve-out that has existed for community health centers in the way that something that is known as the Personal Responsibility and Work Opportunity Reconciliation Act is interpreted. This act is nearly 30 years old and prohibits immigrants who do not have documentation status to benefit from certain federal benefits. Community health centers as well as Head Start were exempted from that, given sort of a bipartisan understanding of public common good. That interpretation was changed effective Monday. As Perla mentioned, things happen very quickly at the federal level, and so we're still trying to understand what this means for community care. Complicating matters a little bit is our very special status as a public entity, community health center, and our relationship with Central Health. There is, in the guidance, although effective immediately, there is a comment period of 30 days, and so we will be working with council in terms of what an appropriate strategy on messaging and what to do in the next 30 days in terms of comment that we might provide to the federal government around some of our significant concerns about what this changes for us. We do not ask about status. We are charged with treating everyone regardless of their ability to pay, and so there could be some very significant fallout from this depending on the interpretations, and we'll be working with council, with our colleagues here at Central Health to determine the best path forward to remain legally compliant. The last thing I will say in terms of context is that although our federal grant under HRSA is relatively small, with the, in comparison to our overall budget. There are a number of other benefits that you are all very well aware of that we receive as a public health center, including FTCA coverage, which eliminates the need to pay for medical malpractice, 340B, which we have talked about ad nauseum. And so all of these things are factors that we'll be considering as we work through what our response will be to this new guidance. Happy to take any questions.
I just want to
Thank you.
share for context, Joint Commission is actually reviewing community care right now, and so we particularly appreciate our interim Chief Operating Officer taking the time this evening to be with us for the updates. So thank you so much, Tara, for your leadership.
Thank you very much. It was a good day today. 3 more days.
Okay, well, thank you, appreciate it. So we will see you next week. Before I let them go, any last minute short questions? I see none, so we will proceed. There is no action item to this agenda item. Oh, Manager Jones?
I don't want to beat a dead horse, or a live one either. But I do think that we need to strategically, either as a subcommittee or other, begin to start putting in place, not that we have the answers to what we're going to face, but a strategy to get this message out. Because this is going to happen quickly. And one of the questions is going to be is, where were we when we knew this was coming down? And so I would encourage us to consider maybe having a work group or whatever we want to
Just
call
to share,
it.
we are in open session, but please know, Manager Jones, that we are actively looking at that, and we'll be providing further updates
So,
in closed
I am-
sessions.
Recommending that we go in closed session right now. We'll just keep this item in case we wanted to follow through, and I will get back to you. So let's take item 2 and 3 into close right now. So I announce that the committee is convening closed session to discuss agenda item 2 under Texas Government Code 551.071, consultation with attorney, and agenda item number 3, which is discuss Central Health owned or occupied real property and potential property for acquisition, lease, or development in Travis County, including next steps in the redevelopment of the Central Health downtown campus, administrative offices of Central Health Enterprise Partners, and new developments in eastern Travis County. And for this item, it is under Texas Government Code 551.072, deliberation regarding real property. So we're going to go into close. Today is July 15, and it's 7:35 p.m. Okay, we are out of closed session. Today is July 15, 2025, and currently it's 8:53 p.m. We had discussed item 2 and 3. There's no action, no motions for those two items. Proceeding to item number 4, confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for next Wednesday, July 23rd, 2025 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. At this time, I'm ready for, to accept a motion for adjournment. Manager Valdez moves it, Dr. Brinson seconds. Any discussions? All in favor?
Aye.
Motion passes, meeting adjourned, thank you.